I'm very grateful to David Hardman and Cody Rowan for arranging this. It's a great pleasure to be here to speak to you. Especially I discovered that UNC is one of the 3 oldest universities, I believe, in North America. And so proud to be part of this great tradition. And you have a lovely, lovely town. And I had a very pleasant night in the Carolina Inn, which I was intrigued to see had photos of its famous alumni all along the walls. And quite fittingly, they had put me in the medical wing, which was full of famous people. And there's one photo that caught my eye, which is this picture of an outdoor anatomy class happening. And they said it was presumably because of the odor. I'm glad to see that there's a long tradition of scientific inquiry here, which I'm proud to be part of. But certainly according to Google, this is perhaps your most famous alumnus, who I confessed I'd never heard of until I got here. But you all probably know this is Caleb Bradham and Brad's drink, which is now Pepsi. And while I make no pretense at being a Caleb Bradham, I like to think that today, some of the stuff we're going to talk about, the ESP Block in particular, is going to be the choice of a new generation of anesthesiologists. So I have no disclosures to make. What I do want to say, though, is particularly when it comes to the erector spinae plane block, this is the product of a tremendous collaboration, and I owe a huge intellectual debt to many, many people with whom I've collaborated and continue to collaborate. What I'm going to talk about today is how we see and understand the block as of really right now. And as you're going to see, it's something that's continually evolving. And it may be that some of the stuff I tell you today may not quite hold true in the months to come. But nevertheless, I think we have a good handle on it ever since we first stumbled upon this not too long ago. The talk was supposed to be titled Paraspinal Blocks, but I'm going to focus mostly on the erector spinae plane block as the sort of seminal example of that. And for those of you who haven't heard of it yet, what it essentially is an ultrasound-guided technique done in the paraspinal region and injecting into a musculofascial plane. And this plane lies deep to erector spinae muscle, which is this group of muscles that runs up and down alongside your vertebral column. And it's performed superficial to the transverse process, so nowhere near the pleura or the neuraxis. And what that achieves, or so we believe, is it blocks the ipsilateral thoracolumbar-spinal nerves over multiple levels. This is a brief introduction to what it looks like when we actually do it. It's ultrasound guided. You can see spinous process, laminar, transverse process if you place your probe in a transverse direction. So those landmarks are easily identifiable. A little bit more laterally, you would see that intersection between transverse process and rib. How the block was first described and how most of us commonly do it is to turn the probe, however, into a parasagittal orientation where we get cross-sections of the bony structures now. So a little bit more laterally, you would see rib and pleura, and some of you may be familiar with that from doing intercostal blocks or even as a prelude to doing paravertebral blocks. But when we do the ESP block, we actually want to look at the transverse processes, and so we're a little bit more medial, and that picture on the right is what we would be looking for to see. The bony shadow changes, and the pleura is also poorly, if not invisible, which doesn't matter because it's not a target for us. What you do in this block is to come in at a fairly shallow needle trajectory. We tend to advocate when people are starting to use the transverse process as a backstop to prevent yourself going any deeper, and then to find this plane just between the erector spinae muscle and the transverse process. And that's determined by injecting a little bit of fluid, what we call hydrolocation, in ultrasound-guided regional anesthesia. And you know you're in the right place when you see this linear spread of local anesthetic lifting the muscle up off the transverse process. And there are a few nuances to what constitutes good spread, and one of them is spread in both directions. So not just in the direction in which you're injecting, but also backwards as well. And that leads to a very important characteristic about the block, which I'll talk about in a subsequent slide. This is a video that just shows a block in actual progress. I'm doing it here, as you can see, in a patient at the end of surgery in the lateral position. somebody who had had laparotomy that was unanticipated, and we're just doing a preemptive block before we break him up. So sometimes you'll be injecting within the muscle. If that's the case, you want to slide a little bit deeper. And there you can see that lifting that's happening, that's separating the muscle up off the transverse process. And you can see what I meant about it going in both directions. They're spread this way as well as that way. And you can, in this case, thread a catheter into the space. We just use any regular nerve catheter set or even an epidural set. And then we can actually use that catheter to maintain the block going forward. I'd like to take a few minutes to step back and talk about how we developed the block, because to me it's a wonderful story of how, good fortune and science sort of meld together to make what I hope is going to be an important discovery moving forward. So it was in late 2015 that my colleague Mauricio Ferrero, who works at McMaster University in Canada, contacted me because he had a patient who described a 4-month history of 10 out of 10 neuropathic pain radiating from his spine all the way into his anterior chest. And it appeared to be centered mostly over the T5 dermatome, but it was also extending a little bit inferiorly. And when Mauricio examined him, this appeared to be a trigger point just lateral to the T5 spinous process. And the diagnosis at that time was unclear. Imaging previously had been negative, and so they thought it was some sort of weird post-herpetic neuralgia that this chap was getting. So Mauricio decided to provide some relief by utilizing the principles of a trigger point injection as well as that of a serratus plane block, by injecting within the muscles. But he couldn't do a serratus plane because the guy's pain was starting all the way in the back. So what he did was modify it by injecting next to the spinous process. And this is a picture from the actual patient. And you will see here that his needle tip is actually placed superficial to the erector spinae muscle. And this was how the first ESP block, as it was called, was performed. But the effect was nothing short of remarkable. The patient had a complete resolution of his 10 out of 10 pain, and then there was loss to pinprick exhibited over T2 to T9 dermatomes, and he had pain relief for at least 36 hours before the pain recurred, but at a lower intensity of 3 out of 10. Mauricio then proceeded to repeat the blocks over the coming days, and at one point inserted a catheter so that he could do the top-ups more readily. The big question for us was how this was working, because it seemed pretty incredible. We tried fluoroscopy. It just showed that the contrast was spreading over the muscle. And at that point, we thought, in light of the fact that this was perhaps a neuralgia with cutaneous pain, that this was accomplished by anterior spread of the injectate to the lateral cutaneous branches. We decided to look at it a little bit further, and so on his next block, we arranged the CT, we injected some contrast, and this is what we found. There was actually no lateral spread of the injectate, not reaching the lateral cutaneous nerves, but unfortunately for the patient, we identified the cause of his pain, and it was not neuralgia. It was actually destructive mets from bladder cancer invading his 5th and 6th ribs. What this, though, prompted us to realize is that the analgesia we were observing could not have solely been due to blockade of cutaneous branches, and there must be something else going on. Enter my second co-investigator, Dr. Sanjeev Adhikari, who works out of Hershey, Pennsylvania, and has been instrumental in understanding of the ESP block. And what we did was some cadaveric studies down in Hershey. And what we found was that if we injected superficial to the erector spinae muscle, it just mainly stained the posterior surface of the muscle. But there was some minor tracking anteriorly through planes between the component muscles of that erector spinae group. However, if we injected deep to the muscle, what we then got was staining of the ventral rami and the foraminal areas, which then now began to provide us with an understanding for how this block might be working. We were getting penetration to the actual beginnings of those spinal and intercostal nerves. And I think without doubt, we have confirmed now in subsequent clinical cases that this is where we should be performing the erector spinae plane block. So we published, it came out in print in September, October, although it was already available by March of 2016. And the original paper describes this evolution of the technique, presents another case of chronic thoracic pain, 2 cases of its use in video-assisted thoracoscopic surgery, and the results of our cadaveric investigation. And you can see here that in these cadavers, a single point of injection provided this spread that goes up and down over multiple levels, and you can see it also too spilling into the intercostal spaces there. So we thought we've discovered this wonderful new technique, but as often turns out in science, many other people tend to have the same idea at the same time or even before us. And it turned out that even a month or two before we described this, a French anesthetist called Cedric Rouet had published this as a small letter in Anesthesia in what he called an intercostal paraspinal nerve block, which he was using in thoracic surgery. And what he was doing was injecting just lateral to those transverse processes over the ribs. But you can see that the concept is very, very similar. He's injecting between the bone and the muscle and injecting a lake of local. And he described some very good results there. But I have to say that the surgeons beat us to it. This is from 2010, a trauma surgeon in the US. And they described this novel technique where they placed catheters into the what they call the extrathoracic paraspinal space. And you can see that really what they're doing is laying a catheter using a cut-down approach, again, superficial to the rib under those paraspinous muscles. And they've gone on and produced evidence to show that this works. So their first study was a prospective cohort of more than 100 patients who had more than 3 unilateral rib fractures. They placed 2 catheters to cover the area and demonstrated significant decreases in pain scores, in inspiratory capacity, and even an impact on length of stay. What is interesting was that in their paper, they commented that ultrasound was occasionally used as an adjunct in obese patients, but wasn't necessary for proper placement. But remember, they were actually doing a cut down. This group in Kansas actually followed up with a prospective trial and compared it against epidural analgesia, which I thought was pretty impressive. It's a small study, but nevertheless, the results suggest that it's very, very effective. In fact, the intercostal group had a significantly greater reduction in their pain scores and a trend to slightly less opioid consumption. But if we go back even further, probably the first of these so-called paraspinal blocks is something called a retrolaminar block, which, when it came out, really didn't get very much attention. And it was described by a group of German anesthesiologists and published in German, which may have been one of the reasons why. But they were looking for an easier way to do a paravertebral. And so they figured instead of going and trying to penetrate the paravertebral space, they would just contact the lamina and inject and place a catheter on the lamina. And it was described originally as a landmark-guided technique, so purely by feel alone. And they postulated that when they did this, what happens was that there were gaps between the vertebrae that would allow local anesthetic to spread again anteriorly into that paravertebral space. As it turns out, they were quite prescient. Once ultrasound came along, it was applied to the retrolaminar block, and this is in 2013. This group published a case report of the use of an ultrasound-guided retrolaminar block, and again from rib fractures, which showed it to be very, very effective. What's interesting about the figure is that they showed sort of different views using, again, a parasagittal view, and this view over here, B, which they've marked there, is essentially what we would now call an ESP view, or a block for an ESP, but they were focusing very much on the lamina. And you can see that the difference between the two sites would appear to be marginal. But as we'll talk about, I think there are some real differences that result from that slight difference in placement. There is a little bit of research to support the retrolaminar block. It's been used in breast surgery with some good results in this small cohort. And this Japanese group did a randomized control trial where they compared continuous thoracic paravertebral with a retrolaminar block. And they found that it was just as effective in terms of pain control, with the caveat that the patients had to deliver more boluses of the local anesthetic to their retrolaminar catheter to achieve the same effect, which is not surprising given that it's a little bit further away and you're perhaps trying to achieve diffusion, therefore you need more mass of drug. It certainly seems a promising alternative to thoracic paravertebral blockade. So I think at this stage we have this group of blocks which we call the paraspinal blocks. And I think there are three major locations at which we can do them. The retrolaminar, which is the closest to the midline. Then we have erector spinae plane blocks, which are done on the transverse process. And then we have a group of paraspinal intercostal blocks that are done a little bit further out. And they could technically be done all the way out. And, you know, if you came all the way into the lateral or anterolateral chest, it probably becomes a serratus plane block. As with all these new things, we have a tremendous explosion of interest in literature, and fortunately, unfortunately, also an explosion in these eponymous blocks. Two of them that have come out, which are worth highlighting, are the MTP block, the midpoint transverse process to pleura block, and latest is this rhomboid intercostal and subserratus plane block. I won't talk very much about the latter because I think it falls into that paraspinal intercostal category, but I will talk about the MTP block because I think it's slightly different and it's worth knowing about. And it was published by Oana Kostash, who works out of the University of Ottawa, and she observed that there were many times when residents would inject superficial to that superior costal transverse ligament instead of penetrating it to get into the space, and the blocks would still work. So they investigated this and found that even if they were within that intercostal muscle and above that ligament, it would still get dense staining of intercostal nerves and even the sympathetic trunk and the paravertebral space. So we now have this block, which I would say is not a fascial plane block. It's, if you like, a modification of the paravertebral. It's an intramuscular injection, which nevertheless provides spread to the paravertebral space. What they also noted in their article was that there was spread in the erector spinae plane, and that's probably because fluid, if you put a needle this way, fluid probably tracks back and enters that space. They haven't published as yet any good clinical data on it, and the question remains as to whether, because you're injecting here where it's bounded by the bones, whether it's a technique that lends itself better to multiple injections or whether it can be performed as a single injection technique. So we'll look a little bit closer at how these blocks work, because I have to say when it first came out, you know, it really looked like it was something out of black magic. What I think we've realized with working on these blocks is that local anesthetic solution tracks very extensively within tissues, much more than we previously thought possible. So that's the MTP block. You can see too with the ESP block, tremendous tracking from a single point of injection. And this is hot off the press. I had to revise my slides literally yesterday because this was published online in RPM late last week, and everybody's sort of talking about it. So it's a cadaveric study from Michael Barrington's group down in Australia. And they performed injections in 10 fresh cadavers each side and injected 20 mils of methylene blue. And they did confirm that there is extensive spread in both a craniocaudal direction as well as a lateral direction. However, most of this spread is, as you might expect, along the muscles. And this is one example from their article showing that spread deep to erector spinae muscle. What is somewhat controversial about their paper is that when they looked at actual nerves, they described staining of ventral rami in only 1 out of 20 of their injections, across 2 levels though in that specimen. There was no staining that they could see of the intercostal nerves. And when they looked at the dorsal ramus, which is the branch that comes up and supplies the back, there 1/10 of the specimens had injectate that had tracked along the dorsal ramus and actually reached the dorsal root ganglion, so there. So their conclusion from this was that the erector spinae plane block may not actually be an alternative or a version of paravertebral block as we have been thinking. And they postulate that perhaps the mechanism is the involvement of lateral cutaneous branches, which you'll remember was our original thought as well. So while I congratulate them for this study, and I think it's a very important and well done piece of work, it is still at odds with what we observe when we perform this in a clinical setting. And it's important to realize that cadavers, although helpful, don't reflect necessarily what happens in real life. You know, patients are breathing all the time, and so there's continuous sort of spread that happens as patients continue to respire after your injection. And we've seen this before with an investigation to the serratus anterior plane block. This was injections performed deep to serratus plane. they were trying to decide if it would cover rib fractures, and because they did not see spread to intercostal nerves consistently, their conclusion was it does not provide analgesia for rib fractures. You can see from that evidence I presented with the surgical literature using their intercostal catheters that that's obviously not true. It does work. And therapeutically effective spread may not be something that you can always detect. This is a study in live patients of a paravertebral block using MRI, and you can see the blue boxes which represent the MRI evidence spread are much more limited compared to the sensory block that these volunteers developed. So the second concept, I think, is that the tissues are a little bit more porous than we think. Again, a cadaver here. They're injecting into that erector spinae plane, and you can see here that as they're injecting, there's fluid actually trickling anteriorly through. So pathways do exist for fluid to pass from that plane into the paravertebral space. And one of these is this, what we call the foramen of Crouvel here, which is the passage through which the dorsal rami and the accompanying vessels travel in order to reach the surface. And again, Ivanusic's study proves that this pathway does exist and it can actually allow passage of dye, just not in the majority of specimens that they observed. We have a study that's coming out. It's been accepted. It's in press, which will be interesting because it'll probably come out quite shortly. But we looked again in cadavers, but this time we used MRI imaging. And we compared what was happening with a retrolaminar block and an erector spinae plane block. And you can see here with the retrolaminar block injecting on the lamina, we get staining of this group of muscles here quite close to the midline, which is more accurately called the transversal spinalis group. And from that staining, there was tracking into the epidural and foraminal spaces. So this confirms that original premise from the German group that there is indeed a way for local anesthetic to track from this area superficial of the lamina forward into that paravertebral space. When we did it on the other side and did an erector spinae plane block, the staining was slightly different. Where we're staining now is mostly this lateral group, which is the erector spinae muscle, not so much a transversal spinalis group. You can see that that's spared there. And from that too, there is still tracking into the epidural and foraminal spaces. And even in this particular instance, anteriorly to involve the sympathetic chain. What was different from the retrolaminar was that there was spread laterally into the intercostal spaces as well, and we now feel that that contributes a significant amount to the effect of the ESP block, which isn't seen with the retrolaminar block. And finally, this is an image from an actual patient shared with me by Mauricio Ferrero in an MRI in an actual live patient, to show once again that when you do an erector spinae plane block, you can get local anesthetic that tracks anteriorly into the paravertebral space and into the epidural space. So I think pathways certainly do exist for spread. It looks like it spreads laterally into the intercostal space, anteriorly into the paravertebral space, and thus it provides a mechanism for blocking both the sympathetic chain and providing visceral analgesia. It blocks the dorsal rami and gives you anesthesia of the back. And it blocks the ventral ramus, which then really gives you anesthesia potentially of the entire chest, because you will get lateral cutaneous branches and anterior cutaneous branches proximal to their origin. I think the question that Ivanusic's study really has brought to the fore is how much of this local anesthetic that we deposit, the 20 mils in an adult, will actually consistently penetrate into that anterior compartment. And the follow-up question from that is, how much do you actually need to get into that space? And this comes to that third principle, which I think underlies the ESP block. Only a small amount of local anesthetic is really necessary to give you analgesia. And researching into this led me to a paper published all the way back in 1984. It was an animal study done in live cats. But what they found was that if you applied very, very dilute bupivacaine to the nerves of the cat, you got this differential block. You could get 100% block of the C fibers with a less than 80% block of A delta and an even lower 50% block of A gamma fibers. And just to refresh your memory, as I had to refresh mine, the A gamma is a motor neuron, The A delta is a lightly myelinated sensory neuron, but it's one that transmits what people tend to call fast pain, so that sharp sensation when you step on a thorn and allows you to withdraw your foot very quickly. Whereas the C fibers, which are unmyelinated, mediate most of the slow, intense, constant pain, which is put at about 70% of nociception. And when you get down to even lower concentrations, you can see that that differential block becomes even more pronounced, with very, very low blockade of degrees of blockade of motor nerves, and certainly of those A delta fibers. And what's interesting is that A delta and C fibers travel through the dorsal root ganglion. And once again, Ivanusic study has shown that we are capable of blocking that by injecting in the erector spinae plane. What this does mean, however, is that sometimes when we do the ESP block, we're not expecting it to be an anesthetic block. If there is acute intraoperative pain, or if there's any sort of sharp pain that the patient feels thereafter when they're conscious, they may still perceive it. It also explains why when we try and test this block, we quite often cannot clearly elicit sensory loss to pinprick or cold, because they're transmitted by fibers that are incompletely blocked versus the fibers that are mediating pain. And similarly, which is probably an advantage, motor block is likely to be less evident. So I think that we have a fairly sound basis for understanding how paraspinal block works. Still lots of things we don't understand, so 6 minus 3 may still be 6. I want to ask, which paraspinal block should we be doing of those 3 broad groups that we presented to you today? You can see they're very closely related, but I think they have different effects. And obviously, I'm biased towards the ESP block, but I want to present to you why I think it is a good choice for doing it. So if we compare it to the retrolaminar block, it's a much shallower target. Because of the shape of the vertebra, the muscle overlying the lamina is much, much thicker. The evidence we have so far is that you get very similar central spread, so you're achieving the same effect with the addition of the intercostal spread I talked about. And in our paper that will soon be published, we show that this spread occurs over many, many more levels when you do an ESP block, thus implying that you'll get a greater extent of coverage if you do an ESP block. If you go out even more laterally, the depth of the target is fairly similar. You get intercostal spread. But what you may not get is the central spread, which we believe contributes if you're thinking about visceral analgesia. If you're just interested in somatic stuff, and again, I'll refer to rib fractures as perhaps the best example of this, it probably doesn't matter whether you do an intercostal paraspinal or an ESP block. The other advantage, again, is once you're close to the midline too, is that we'll cover the dorsal rami, and I think this is going to be one of the more exciting developments. Now, because we're injecting into this plane, we get a very, very effective single-shot technique. It covers multiple dermatomes because this musculofascial plane versus a fat-filled space like the paravertebral space or even the epidural space, it allows fluid to spread much more readily, as you can see here. And one of the good news is that you could probably make a case, as there is already being done for TAP blocks, to inject liposomal bupivacaine and extend the duration of this block. So I'm sad to report that your colleagues down the road at Duke have sort of beaten all of us to the punch and already published a case report where they use liposomal bupivacaine in a case of breast surgery to provide long-lasting analgesia. You can also thread a catheter, so that plane, once it opens up, is very amenable to passing a catheter into it. And catheters, we are finding, are very useful because they allow you to both augment the degree of analgesia by giving an extra bolus, so you can increase the amount of pain relief somebody is getting. People may wake up with pain that they report at 5 out of 10. If you give another bolus, it drops to 2 out of 10. And obviously, it can prolong the analgesia well beyond the duration of the local anesthetic. We are currently looking into what might be the optimal way to use these catheters. A variety of regimens have been described. If you use a continuous infusion, we certainly find that higher rates seem to be required, again, just to deliver an increased mass of drug. People are also using boluses, either delivered as a patient-controlled bolus or intermittent boluses. And if you have the newfangled pumps that will deliver program intermittent boluses, we currently feel that that might be the best way to go. And a word on effectiveness. I think that nowadays, when we think about regional anesthesia, we kind of have to get away from the brachial plexus blocks or the nerve blocks where we get a completely dead arm, insensate limb, and think about analgesic efficacy as being relative. What our goal is to get patients to a level where pain is tolerable, all right, and that the use of analgesics, particularly opioids, are at acceptable levels. And guess what? I mean, epidurals and paravertebrals, much as we hold particularly epidurals up to be the gold standard, are not perfect. This is just one example of a study that compared the two techniques head to head, and you can see the tremendous range of pain scores going all the way up to 8 out of 10 in some instances that occur with both techniques. And it stands to reason that it may not be a fair comparison when you're weighing ESP against paravertebrals, because we're depositing them in different places but expecting them to act in the same structures. So clearly, if you put all the local directly into the epidural space, that's going to give you the most intense block. Paravertebrals, a little bit less so. You probably get epidural spread in a lot of cases, but again, not as intense. And then by the time we get out to the ESP, it's trickling through. But nevertheless, it appears to function pretty effectively and be a good alternative to those two techniques. And so I must give credit to Jerry Jones, who at the recent World Congress stood up and coined this term, which I think is very apt. He called the ESP a paravertebral light. And, there's nothing wrong with a light beer, right? All you want is enough buzz to give you a good time. Because guess what? Intensity isn't everything, right? And this leads me to the other, I think, big advantage of the ESP block. I think it is a safe block. And I'm going to argue it's safer than those other two alternatives. Really, right now, the main thing we caution people to watch out for is local anesthetic systemic toxicity. And so I always add epinephrine to the local anesthetic. I make sure I don't exceed maximum recommended doses, and you should always be monitoring patients for at least 30 minutes. You've seen now that epidural spread is possible and probably does occur. But again, because now not very much of it is getting into that space, hypotension is something that I think is possible, but we really have seen, I've never seen it yet. I've heard maybe one report. It's something I think it's very rare. And if you think about paravertebrals and their association with hypotension, again reported, but much, much lower incidence compared to epidural analgesia, and the meta-analyses will bear that out. Compared to paravertebral block, I think the risk of pneumothorax is not there. Again, interestingly enough, there is a report. And my only comment to this is anybody can hit anything depending what you do. I don't think the risk is inherent in the technique. You're miles away from the pleura, but if you choose not to visualize your needle properly and not be conscious of how far you're putting in, bad things can happen. When it comes to, the really, really major complications like hematoma and abscess in the vertebral canal, I think because we're not putting the needle there, those risks are negligible. And certainly patients are a lot more reassured every time I tell them, I'm going to give you an injection into the muscles of your back, which is what the ESP block is, versus saying, I have to put a needle into your spine. Patients are much more willing to accept that. And it's a simpler block. We have a discrete endpoint, which is bony contact versus loss of resistance. And this was the original premise for the German group when they were touting the Retrolaminar block. And when you use ultrasound too, we have a very, very visible target. It's bone versus pleura, which is the target that we want to see in the paravertebral block. It's very hard to see the pleura. Oh, go ahead.
Sorry to interrupt. It's going to be on this video.
So resume the call. Apparently the call was okay. So if you see the call was muted, it stopped for some reason. So let's see if now. Can you check your computer real quick? Let's see.
I'm testing.
Yeah. They should be picking up.
Yeah.
Yeah. I'm
The
sorry.
mic did fall.
It is. It's on.
Oh, your microphone.
Felt. That's probably why actually.
But you should be picking up here too.
Yeah.
We're good? Okay, so let's go back to your. Right, okay. We're here and we'll go back in. All right, you should be
Okay.
fine now.
Okay.
Are you in the right side?
Yep, this is good.
Okay.
So, as I was saying, the other advantage is I think it's a much simpler technique. So we talked about the fact that you're touching bone if you choose to do a landmark guided technique. And interestingly enough, this could be done possibly as a landmark guided technique. However, I think what we realize is that you need to determine that you are not intramuscular when you inject for maximum efficacy. So for that reason, I think in this era we should be doing ultrasound. So as I said, compared to say a paravertebral block where we're looking for the pleura to depress and we need to get close to the pleura isn't always visible when you get to the true paravertebral space because you can see here that the lung curves down in a way so when your beam hits that pleural line, it actually reflects away from your beam, which is why we don't see the pleura well when you're truly imaging a paravertebral space. But in the ESP block, we are just looking for this very prominent bony surface, the transverse process. And, you know, it's something that only requires a single point of injection. There's this ongoing debate about whether with paravertebrals you should do multiple injections or single injections. That debate doesn't exist with the ESP block. And it's a versatile block. So we originally described it as being done at T5 for thoracic analgesia, but what we also realized looking to this is that the erector spinae muscles are a group that extend all the way from the occiput down to the sacrum. And we extended this early on to injection at T7 or T8 to provide abdominal analgesia, particularly of the upper abdomen. You can also do this at T10, T11 to provide analgesia of the lower abdomen. And thus, you know, really is a block that can cover the entire torso. And once again, it's that spread that happens from that point of injection, which occurs in both directions, which makes it such a valuable technique, I think. So how can we use this? The caveat here is that we're still awaiting RCTs, so all this comes from case reports and anecdotal reports. But for those of you who do chronic pain, you know, it's found tremendous value because these patients, when they have pre-existing pain, the block always does something. Doesn't always take that pain to zero, but it certainly brings it down to a tolerable level. And I've seen that personally in a few patients. So anybody who's got chronic thoracic or abdominal pain, this is a block that can be worth trying. We described it first in the thorax. So thoracic trauma or surgery in many centers, I'm told it has replaced paravertebrals or even epidurals as the go-to for rib fractures, again, because of its simplicity and the relative lack of contraindications compared to those other two techniques. People who are otherwise not comfortable with blocks are happy to do the ESP block. It's been described for thoracotomy, for video-assisted thoracoscopic surgery, breast surgery, and for superficial chest wall, even as an anesthetic block. And there it might be suitable for that purpose. Abdominal surgery, we described it in ventral hernia repair and bariatric surgery initially. And since then, people have used it for a variety of things. And Cody was telling me, too, that you guys are using it here for your abdominal surgery. And I think Monica used it successfully for a donor nephrectomy that involved an upper abdominal incision. So that's great. A very, very recent report even suggested for a radical prostatectomy, it was something that was useful. This, I think, is a new frontier which is very, very exciting. Cardiac surgery is something in which regional anesthesia has been talked about, mainly, you know, in terms of thoracic epidurals and paravertebrals. But the main worry, understandably in everybody's mind, is the anticoagulation that goes on in these patients, and that is something that worries us. So the question is, is the ESP block safe in an anticoagulate patient? If you look at the recent guidelines that ASRA released, there is now a statement in there about non-uraxial blocks, and they advise that you should consider that risk dependent on a few factors, and chief among that is the compressibility of the site, the consequence of a hematoma if it was to develop at that site, and the risk of hitting a vessel that might cause, say, a major hemorrhage. And I think with the ESP block, the chances of that are pretty low. The site itself is compressible because you're injecting onto a bone, so you actually have a hard surface with which to press against and compress effectively. And again, Sanjay Adhikari and Hershey has led the way by doing this in patients undergoing left ventricular assist device implantation. And these patients are heavily anticoagulated post-operatively, as you might imagine. But they were having tremendous pain, and he performed a series of rescue blocks in these patients with tremendous success and no complications. And now this, I think, has become the standard in their institution. And I've recently heard that other centers are doing it as well. It's been described for median stenotomy, and here you would need bilateral injections. So the Stanford group published a case series recently, and some Colombian colleagues of mine will be shortly publishing a more extensive case series in the Journal of Cardiovascular and Thoracic Medicine, showing that it can be effectively used and that catheters, again, can be placed. At the World Congress, we heard from a group in Hanoi where they have done, I think, well over 100 patients over the last year. The anesthesiologist in question taught herself to do a block. She was a cardiac anesthesiologist who had never touched a needle in her life except in residency, and she taught herself to do ESP blocks. And they now do their cardiac surgery apparently with minimal to no opioid. So ESP block, I think, is progressing even beyond thoracoabdominal analgesia. We've seen reports, and this is from Mauricio, using it for upper limb surgery, for chronic shoulder pain, for spine, and even a case in terms of covering the hip. I want to show you this video because...
Where are you feeling your pain usually? ¿Dónde siente el dolor normalmente?
This is the of the report from Mauricio in that chronic shoulder.
¿Y cuándo siente el dolor más?
Cuando levanta el brazo.
So you are feeling when you are the pain when you are lifting your arm. ¿Eres capaz de levantar más el brazo de ahí?
Me duele.
¿Te duele?
Me duele más si lo levanto.
It hurts. From 0 to 10, de 0 a 10, how your pain usually when you are lifting your arm? Cuando estás levantando la... 8 out of 10. Try to lift it more, please. Trate de levantarlo más. Okay.
So Mauricio decided to try a block,
okay.
A higher up.
Do your movement.
Perfect.
¿Cómo está el dolor?
Queda un 5%. Casi nada.
Almost zero, right?
Yeah.
I can't believe this.
So when Mauricio examined him, he had some evidence of mild sensory loss in that distribution you can see. And you can see, interestingly enough, even some sensory loss over the hand. But what was remarkable when I first saw this video was the complete absence of motor block. And ever since then, every time he's done it, he does it quite regularly now for shoulder pain. And I have some colleagues who've used it preoperatively for somebody coming with rotator cuff issues for repair of that. After they do the block, the patients can all move their arm pain-free. There's no motor block, but there is a great analgesia. So again, we're trying to understand how an injection at T3 might do this. This is the spread that occurs when you inject at the sort of T3 level. Again, it spreads down a little bit, but it also spreads up. And essentially, you know, there are planes that are continuous with the erector spinae that go all the way up into the neck, although the muscles there are a different set of muscles. And when we look closely, we can see, again, local anesthetic just trickling upwards, getting close to the brachial plexus. And again, I think it's that concept of differential block. We're getting enough that we are, perhaps again, you know, acting and freeing up the muscles here around the rotator cuff area, and maybe just enough up to the area of the brachial plexus to give you analgesia, but not motor block. This slide is just to show you those different muscle groups and how there is this potential plane that allows anything injected here to track up along the scalene muscles and reach that area. This is the latest advance. So this is Josh Melvin, who's an anesthesiologist in Sacramento, California, a great guy. And he has been doing, I think he was telling me now, as a group, they've done 200 of these cases. He's done 100 of them. And a report has been published online in the Canadian Journal of Anesthesia describing their experience. And what he was doing was that for lumbar sacrospine surgery, he was performing ESP blocks. He was doing them higher up at T10 to 11 to stay out of the surgical field and leaving catheters as well. And again, because that spread happens in such a pronounced fashion, that's able to provide analgesia that extends down into the lumbar spine. So we're injecting, and this time we're targeting dorsal rami. That's the important nerve. We're not interested so much in the ventral ramus, which would contribute to the lumbar plexus. And what was reported and what we're discovering is that patients need very, very little opioid. Again, there's no motor block of the lower limbs that happen. And even if you are using neuromonitoring, there appears to be no discernible effect on somatosensory evoked potentials. And I will tell you, even motor evoked potentials, based on my experience. Because the next one I'm going to show you, you are the first group to hear about this and see this.
You're all awake now, okay? Surgery's over. Do you have any pain at all in your back?
No.
No? How'd you feel? Just sleepy? Okay. Good. All right, you just ready?
Yeah.
Can you sort of bend your legs for us? Yeah, great. Lift them up off the bed. Yeah, and the other one too. Does that hurt you at all?
No.
You're not hurting in the back at all?
No.
No? All right. Arms up too. Perfect. You want to try sitting up a little bit? Just a touch. Yeah. Can she just roll for us? Oh, nice dry incision. Good. Come back again. Perfect.
So what this young 22-year-old man has just undergone is a T2 to L1 scoliosis correction surgery. I gotta say, I was blown away, and it's something that's really got me excited here, because this is what we did for him. So because of the extent of surgery, I actually did 4 ESP blocks. So bilateral again, T3 and T10 to try and make sure I got the full extent of incision. Used the maximum recommended dose of bupivacaine in this case with epinephrine. He had some fentanyl for induction. And because I was chicken, I gave a milligram of hydromorphone just before the incision. And I left out remifentanil, which would otherwise be our standard drug during the case, and instead ran dexmedetomidine and ketamine. As you can see, pain in recovery was 0 out of 10. And that's him, his picture taken by his father in the ICU 3 hours after the surgery. He was off PCA on oral tablets by the next morning and just used 7 doses of 1 milligram over 24 hours. And what was remarkable too is that his pain remained controlled for 36 hours, which I think really, I think opioid-free anesthesia is a concept that we really, really need to pay attention to. I think opioids may not be as essential and certainly may be more harmful than we've previously been led to believe. And I think there are certainly ways that we can minimize patients' dependence, and what we do intraoperatively can perhaps influence that. I certainly think avoiding remifentanil is a big step in that direction. So really for me, I think this is an exciting time to be part of regional anesthesia and acute pain. The ESP block, I do sincerely believe, is an important advance. I mean, it's effective in a range of situations. It's simple. It's safe. There's lots of stuff that's out there now. This was of the 13th of May, and I have to say 2 days later, last night while I was checking, it's gone up by 2. So it's an area that's evolving very, very rapidly. However, we are still awaiting randomized controlled trials, and I suspect those will be forthcoming very, very soon. We do have unanswered questions. You know, we would like to see large cohort studies or RCTs to tell us how reliable they are, and perhaps ascertain what the optimal technique is and the best way to dose them. It would be great to see how they do compare in terms of efficacy to our gold standard blocks of epidurals and paravertebrals, and whether or not there are certain populations in whom we should still be doing these more invasive blocks, and then other populations whom the ESP is the better choice. Head-to-head comparisons between paraspinal and ESP blocks, I think, are a lower priority, but they're still an interesting question. Are there situations where we could use this as an anesthetic block? I think for now, certainly based on my experience and what I hear from others, is that because there's that variability in penetration, I would not always lean on it to consistently provide anesthesia, unless, again, it's very superficial surgery. There is a question of how to maximize duration, whether things like dexamethasone will prolong the block at all. You guys down here have the benefit of liposomal bupivacaine, so that may be one option. And then catheters, if we do put them in, how should we best use them? For now, I'm going to say that, you know, if you're considering using the ESP block, I would use it in situations where you would otherwise do an epidural or paravertebral, but for various reasons, it's not feasible. Because you know what, this block, as I've said many times now, I think it's a simple, safe, and reasonably effective alternative. So there's very little to lose by trying it. So to sum up, an alternative, as I've said, to these other more invasive blocks, tremendous potential, particularly I feel in areas such as spine surgery. There is a sound anatomical basis to explain how these blocks work. They are simpler, they are safer, they're almost as effective. Bear in mind that don't go in expecting them to completely eliminate your dependence on other analgesics. You may still need to do that. It should be used as part of a multimodal regimen. And I think that is the way to ensure that you get the best possible results for both yourself and your patients. These are some resources you can go to that are currently available if you want to know more about the block. But otherwise, I'm happy to take any questions. Yes.
Blocks, certainly the erector spinae. I found it interesting that the Mariso used a 0.5%. It seemed like concentration of local anesthetic, performing appears to be more of a pain clinic type situation with that gentleman with the shoulder pain that was such profound relief. Something with the tap block that we saw after reviewing the literature and performing ourselves was just such variability in the duration after single shots. And so, at least transiently, we explored, should we be placing catheters in them? And you seem to have great results with the most recent sort of spine surgery you mentioned there, using a single shot, a multimodal analgesic with multiple infusions intraoperatively. And I just wanted to ask, you had great results even 36 hours later. If we're going head-to-head, say, with an epidural, just in your expert opinion, I realize research, as you said, needs to be ongoing. Should we rely on placing a catheter with this erector spinae, or should we think that we're not seeing a lot of rebound pain? A single shot, may be good enough.
So it's a good question. I will say that the variability in the duration of the ESP block is still present. Talking, again, leaning on rib fractures, where I think most of the work is being done, the observation is that the analgesia there sometimes only of a couple of hours to longer, and so a lot of places, if it's severe injuries, are putting catheters in for that very reason. It does wear off, and we think that perhaps vascular reabsorption may have something to do with it, because it is muscles very well vascularized. I think the analgesia we see with that spine case, and with a couple more that I have done where we've had similar opioid sparing for prolonged periods in the post-op period, is not the block alone. I certainly believe that having started to read a lot, and I encourage you, it's a fascinating area to read about opioids
and hyperalgesia. I think all those things are very, very valid, and I suspect that you need to combine all those modalities to produce that degree of sustained analgesia and opioid sparing that we observed with that case. So for now, though, in regular applications, I would say place a catheter if you can. We were using, I'm quite happy right now with 0.25% butyrification. It seems to work well. But I certainly am going to be using very, very little remifentanil going forward, where I can, in exploring that, because I think that may be a big contributor to rebound pain. Who knows if rebound pain is actually a phenomenon induced partially by opioids. But, so, short answer is, catheters if you can. Otherwise, yeah, sometimes you're going to notice that your blocks may not be as long-lasting as possible. Thank you. Yes?
I think you said that you don't have XBRL available
We don't.
in Toronto. So what about, we do have it, so what about that as an option to the catheter?
I think it's a good option based on everything I've been hearing from colleagues. People are certainly using it, and so it seems to be providing good results. But this is anecdotal reports. I'll take one question in the back.
With the new ASRA guidelines that came out a week and a half ago, with the INR limitations now for neuraxial techniques being down to 1.2, I think that may potentially change our practice here for thoracic analgesia and also for upper abdominal analgesia. You know, for a long time, this institution has been weighing heavily on the use of thoracic epidurals. But with these new guidelines, you know, 25% of our patient population is now unable to receive a neuraxial technique that they would have received at this institution. And I think this is something that our group should explore, especially in the context of our enhanced recovery pathways for both thoracic surgery and also for surgical oncology. Sort of making a statement more than a question.
That's great. I couldn't agree more. I think at the end of the day, though, you know, without sort of rushing out saying do this in people who are crazily anticoagulated, where there's a true benefit, you think, from providing them with a degree of truncal blockade, then I think that risk is worth taking in. It theoretically is minimal. So, David, you had a question?
Yeah, two quick questions. Number one, how much of this effect do you think is due to systemic absorption of local anesthetics? Have you really been able to tease